Hello again, everyone. Welcome to Chapter 17. This is Session 5 about blood, one of the unique types of connective tissue that doesn't have a solid extracellular matrix, but rather a liquid one. And with that liquid extracellular matrix, it can connect tissues in different systems. So the easy stuff is that, yes, it's transporting, it's delivering oxygen and nutrients to body cells. It's also removing metabolic waste either to the lungs or to the kidneys or to the liver for elimination. And thirdly, it's also helping with signaling. It's helping move signals transported through the blood that we call hormones from the source, the organs, the endocrine systems organs, to organs that have receptors for those hormones. In addition, it's helping sustain conditions for basic physiology. This includes temperature, includes pH, a buffer, including one we've talked about before in the respiratory system, bicarbonate, and certainly maintaining proper osmotic and fluid requirements. Too little fluid, dehydrated, too much fluid, we'd be hypertensive or edemic. All right, so we're maintaining osmotic conditions so that water and the material dissolved in the water moves properly in and out of cells or around cells and so forth. Lastly, we have defense functions, which include preventing losing those proteins and platelets that we work so hard to make, as well as immune system functions. That includes soluble proteins we call antibodies or immunoglobulins, and white blood cells, otherwise known as leukocytes. And we'll talk about those different kinds of leukocytes here in a few minutes. Now, quite a bit of numbers here. We don't want to get too crazy, but we're going to get some basic situations here. Of your total body weight, blood is not quite 10%. It's 8%. It's about the equivalent of your head. You have about 5 to 6 liters of blood for males, 4 to 5 for females. Again, lots and lots of different things here. So the key is concepts. For instance, the formed elements, these are cells, all right, cells and cell-like structures. We see that we have an approximately about 45%. Sometimes it can be a little more, sometimes it can be a little bit less. Those formed elements include platelets, white blood cells, and red blood cells. Then we have in the white blood cells, we have a population. We also have, proteins that are in the soluble side and other ions and so forth. The fluid part here is what we call serum. All right. You can call it plasma when it has these clotting factors. So serum without the proteins that clot and plasma with the proteins that clot. Now, when you spin blood down, you get this red layer, you get this very, very thin white layer, and that's known as a buffy coat. That's because that thin white layer is white blood cells. If you have a condition called leukemia, what happens is more and more of this fraction, and sometimes even up and above 50%, what you'll see is a white layer. And that's because they're white blood cells. They don't have hemoglobin. So normally it's less than 1% or maybe just about 1%. That's called the buffy coat. Hematocrit, on the other hand, is the percentage of the 100% of the blood volume occupied by red blood cells. And normally that's somewhere in around 40 to 50%. It varies by male, female, can vary by age or disease. And so we've talked about the formed elements. Now let's talk about another super important group of molecules in the blood, and these are plasma proteins. The most common class of plasma proteins are known as albumins. Structurally somewhat similar to egg white. All right, somewhat similar. That's what the word albumin means white. Very, very important in proper osmotic pressure. And if you can't maintain proper osmotic pressure, you get things like edema. Blood exchanges fluid with tissues. And so if you don't have proper osmotic pressure, what happens is you get inappropriate distribution of fluid outside of the bloodstream. And so you get edema in the arms and the legs, or even worse, sometimes in the belly. And that's why albumins are important. They're manufactured by the liver, and that's one of the manifestations is edema when the liver's not working properly. The second thing about albumins is that they have a hydrophilic exterior and a hydrophobic interior, which means they can transport things that are not necessarily very water soluble. And that includes things like testosterone and estrogen, cortisol, steroid hormones, even non-steroid hormones like thyroid hormone, or a lot of drugs that we administer are usually a little bit hydrophobic, so they can get across plasma membranes. And so albumins have a very important role as transporters in that regard. We also have somewhat enzymatically active proteins we call globulins. We have alpha globulins, we have beta globulins, and we have gamma globulins. Alphas and betas are somewhat like albumins in some cases. They can transport substances, but they also include enzymes, and enzymes are super important in the clotting cascade when we have signals to induce clotting. So they're enzymatically active. Gamma globulins are part of the immune system. They're manufactured by special cells and are reactive to certain molecules that we encounter in our world. And so we call these things immunoglobulins. IgA, IgM, IgG. Those are all examples of different types of antibody immunoglobulins. Thirdly, we have a type of protein known as fibrinogen. And you can see the ogen there means precursor. This is the soluble precursor to an insoluble protein known as fibrin. So when fibrinogen is activated, it's a form of cleavage. When you cut some pieces off, the fibrin will polymerize and become insoluble. So it's very, very important in blood clotting. All of these proteins are made in the liver, with the exception of gamma globulins, which are made by a certain type of lymphocyte, the B cell lymphocyte. These are the antibody manufacturer white blood cell. Now, your blood is a very dynamic tissue. It is one of those tissues that has some of the highest rates of cell division. Now, it normally doesn't happen in the blood. It happens in the bone marrow or in the lymph nodes or even in the liver for that matter. But the process of creating blood cells, those formed elements, is known as hematopoiesis. Hematopoiesis. Now, hemopoiesis, I don't hear that much, but I hear hematopoiesis quite a bit. And the formed elements in the blood all arise from what is known as a pluripotent stem cell. This cell can be created into any of the cells found in the bloodstream. All right. So it's pluripotent. It means that it can create any cell in the blood cell family. These include things like white blood cells, for instance. And so these are the precursors of white blood cells over here. This is the precursor of platelets. It's a megakaryocyte. That's going to make platelets. And then over here on the left, we have an erythroblast. This is a precursor to a red blood cell. Depending on the signals that these cells see, they will preferentially differentiate into one of these cell types. And when they finally mature, like for instance, an erythroblast will turn into a mature red blood cell. It'll lose its nucleus, form this biconcave shape, and now will live about 4 months as a mature red blood cell. Whereas these other ones, again, depending on which signals they see, can either differentiate into what we call a lymphocyte or a monocyte. If you've ever heard of mononucleosis, that's an abundance of this monocyte. Or one of the granulocytes like neutrophils or eosinophils or basophils. And again, that megakaryocyte gives rise to subcellular fragments called platelets that are super important in clotting. So let's talk a little bit about white blood cells, otherwise known as leukocytes. Again, we have lymphocytes, which generally reside in the lymphatic tissue, in lymph nodes or the thymus, okay, or in the digestive tract and Peyer's patches or that sort of a thing. We also have monocytes, which is another type of white blood cell, and then we have the granulocytes. Now, there's more than this, but these are the big three: eosinophils, basophils, and the most numerous, neutrophils. Neutrophils are by far the most abundant class in the white blood cells. It's easily half, almost 3/4 of all the white blood cells. Lymphocytes are pretty abundant as well. Again, they reside primarily in the lymphatic system, lymph nodes and so forth. And we have small percentages, or they should be small. If not, then we have a sense of why those cells might be overabundant. If you have an overabundance of white blood cells in total, we would call that leukocytosis, and that's quite common when we have infections. We have too few, like for instance, maybe you have an HIV infection. One of the early manifestations of HIV infection is a reduction in white blood cells. So when it comes to population of blood cells, by far the king are the erythrocytes. All right, by far the king are the erythrocytes. In terms of abundance, the anagram is never let monkeys eat bananas. So it's neutrophils, lymphocytes, monocytes, eosinophils, and basophils. All right, this is a good slide to know. I would not get too hung up on the concentrations here. Where I would go is over here on the right with the basic functions. For instance, a neutrophil is a phagocyte. It primarily ingests invading bacteria in the bloodstream. Eosinophils are important in parasitic infections, like if you get a parasitic worms, that sort of a thing. They also are involved in allergies and asthma. You even have certain eosinophilic types of skin psoriasis. That's a certain type of psoriasis. Basophils, they are histamine. All right. They release a lot of histamine. They're often involved in allergies and basic inflammation. They also have anticoagulants as well. Agranulocytes, these are lymphocytes, right? They're really about the sort of what we would call acquired immunity. That is to say, you have to be exposed to something. And when you're exposed to something, these lymphocytes will develop in special ways in order to respond to that specific type of invasion. That's where we get antibodies. This is also how we stay clear of most cancers in our lifetime. Cancers happen in every person, but the incidence of clinical cancer is less than 1 per lifetime. What happens in cancer oftentimes is they learn how to evade certain types of lymphocytes that would attack and kill cancer cells. Then we also have this other sort of non-specific monocyte. These develop as phagocytes as well. They also will move out of the bloodstream. This is called extravasation, and they will move out into tissues, like into muscle cells or into the CNS or other tissues outside of the bloodstream and serve as a sort of a phagocyte in those tissues. And then lastly, we have platelets out here. These are subcellular fragments. These are some of the vanguard when it comes to inducing clotting. What happens is they come into contact with collagen and other proteins that shouldn't be seen in the bloodstream. So if there's some disruption of the cell layers of a blood vessel, or their tissue proteins come into the blood, that will activate platelets, which then will begin inducing clotting. If you were to take a sample of blood and put it onto a microscope slide, and what you do is you make a nice thin layer, that's why it's called a blood smear, you probably would be unlikely for you to see all of these cells at once, because things like basophils and lymphocytes are usually pretty few and far in between. This is what you call a lucky slide in terms of all these different cells. It's entirely possible you'd see neutrophils. always see red blood cells, erythrocytes, unless there is truly some problem. All right. So that's a neutrophil here. This is also a neutrophil up here. You can tell because of this wonky nucleus. Now the eosinophil has a wonky nucleus too, but you can see the reddish color. Eosin means acid, so that's an acid stain, and so they typically will stain a kind of a purple reddish, if you will. Basophils mean a basic stain, and they look like very dark purple. Then you got lymphocytes, monocytes here. But again, this is a really rare slide that you would see all of them. And here's a platelet subcellular fragment. But a nice representation of these cells. As mentioned previously, the capillaries actively exchange fluid with a compartment in the body that is known as interstitial fluid. Extracellular fluid includes interstitial fluid as well as blood plasma, and interstitial fluid is actually a greater percentage of extracellular fluid. So as blood flows through capillaries, so we're coming in from an arterial into a capillary, what we get is we get a net exit of blood flow out of the capillaries. This is known as filtration. Part of that's due to the blood pressure, the fluid pressure pushing fluid out, keeping proteins and cells in. And we also have osmotic pressure, which counters that. So while we are pushing fluid out, osmosis is actually pulling fluid back in. On the arterial side of a capillary circuit, the net is for fluid to flow out. But as you go down that capillary circuit, the pressure keeps dropping. You can't move fluid without going from an area of higher to lower pressure. So we started at 35 millimeters of mercury. Now we're down to 15. Well, now this push out is less than the pull in. So on the venous end, the net flow back into the blood vessels is due to the osmotic pressure. So we're actually pulling fluid back in. We don't pull in all of it. About every day, you lose about 3 liters of fluid to interstitial fluid. But if you start screwing up osmotic pressure, like for instance, if you have liver disease or something, now this doesn't work. And you lose a lot more fluid. You don't pull it back in because you don't have that osmotic pressure. If you don't have the proteins, you don't have the pressure, you don't pull it in. And we get this term. It's for excess fluid moving into the interstitial fluid. That is called edema. Normally we have fluid remaining, and then how do we get it back into the vasculature? We obviously don't just fill up with fluid and swell up like a balloon, though sometimes it feels like that. What we have is we have mechanisms for returning this fluid back to the blood vessels and blood circulation, and that is our lymphatic system. So any excess fluid that flows out should be captured eventually by the lymphatics and returned to the bloodstream through the lymphatic system. The process of maintaining vascular flow in the face of injury or perturbation is known as hemostasis. That is, how do we maintain a flowing blood vessel given that we might have an injury or trauma or something along, or an infection, and so forth. So there are 3 main steps, and this isn't true for every single blood vessel, but we're just talking about your average run-of-the-mill capillary, arterial, meta-arterial kind of level of blood vessel, venule kind of thing. Anything bigger than that, we may have to have more comprehensive treatment. But it starts with injury, where we have an issue where we disrupt the blood vessel, where we get a breakage or that sort of a penetration or exposure of the blood plasma to tissue proteins like collagen and other types of non-interior vascular proteins. So we get the injury there. And the first step, if the blood vessel is small enough, we're talking about meta-arterioles and arterioles, small muscularized vessels. The initial thing is that you'll get an onset of an inflammatory response that leads to contraction of the vascular smooth muscle in that area. We call that vascular spasm. Larger vessels like arteries not going to do that. There's just not enough muscle there and too much pressure, that sort of thing. We're talking about smaller blood vessels. We get vascular spasm. Then we get an initial what's called platelet plug formation. So the platelets are seeing inflammatory chemicals and they're releasing chemicals themselves that are activating other platelets. And these platelets kind of turn into little sticky Velcro like balls of protein, and they will stick together and they will stick to the vessel wall, particularly in a constricted area or in a breakage zone. Like say if the wall was disrupted here, they'd start adhering in this area. That is known as a platelet plug. That is not a clot. It's much less durable than a clot, but it's beginning to initiate the process of clotting. Now, in very, very, very small, like capillaries and so forth, platelet plug might be enough. Might be enough. In fact, if you take antiplatelet drugs, like what we call blood thinners, what you begin to see is purpurae underneath the skin sometimes, where there are little breaks in the blood vessel, and because the platelets can't form plugs as well, the blood bleeds a little bit more than it normally would, and you get these little purple splotches of bleed underneath the skin. So platelet plugs do the vast majority of minor work with small little thises and that's of blood vessel breakage. But if you need more than that, then we go into the formal coagulation pathway, where we are taking fibrinogen, the precursor, we're cleaving it into an active protein that will then polymerize with other fibrin, not unlike what's like we see in sickle cell anemia. You know, in sickle cell anemia, you have just this right thing when the oxygen levels drop. The hemoglobin forms polymers, and that causes the red blood cell to sickle. It's a very similar process here, only this is supposed to happen. And so we get the formation of fibrin meshwork. It's kind of shown here. It's not super easy to see, that traps red blood cells and white blood cells and platelets and forms a much more comprehensive, much more durable clot. Now, we don't want to completely clot across here because that would occlude blood flow. So there are some factors that prevent it from completely sealing off the blood vessel if possible. So what you're trying to do is restore a flow of blood to that vessel, because anything downstream of this vessel isn't going to get served. Now, what about this figure on the right? This figure on the right gives you a little more of a molecular insight as to what's going on when. For instance, if you have a damaged cell wall, the cells in there will release factors that then cause proteins to activate. And it's called a cleavage cascade. So this protein gets cleaved and now it's in its active form, and it cleaves other proteins and now they're activated, and it cleaves them, and so forth and so forth. It's a cleavage cascade. And this is the intrinsic pathway, damaged cell wall. And then we have what's called the extrinsic pathway. This is signals and proteins coming from cells outside the bloodstream that happen to be damaged or inflamed. And so you have there's actually a third pathway as well. They're all going towards this activation step. You see these big boxes right here? These big boxes, this is the conversion of prothrombin, a soluble inactive protein, into an active protein called thrombin. And thrombin's the main enzyme that converts fibrinogen to fibrin. So thrombin is an enzyme that then cleaves fibrinogen, and now fibrin begins to polymerize. So they all converge on this common step of activating thrombin, which in turn activates fibrin. This over here is kind of where hemophilia comes from. They've identified these through families that have blood clotting disorders and so forth. A very, very interesting biochemistry, but again, most people don't have enough experience in these kinds of classes to really understand what's going on, but it's very cool. So that it can either be the damage of the vessel or it can be damage to the tissue around the vessel, but they both converge in this clotting step. Thrombin activation that then converts fibrinogen to fibrin, forms the meshwork and traps red blood cells. And now a little bit about red blood cells. If you remember from the hematopoiesis slide, and if you haven't remembered, then I invite you to go back. I mentioned that you start with that pluripotent stem cell that can form into any of the blood cells. Well, if those pluripotent stem cells and those precursors see a hormone known as erythropoietin, primarily made by the kidney, if the kidney is sensing low blood oxygen, it begin secreting this hormone, erythropoietin. And the erythropoietin will induce those precursor cells to form red blood cells. We make 2.5 million red blood cells per second. It's pretty amazing. That's one of the reasons why people feel so fatigued and so forth with things like chemotherapy, because chemotherapy actually affects rapidly dividing cells. And guess what a rapidly dividing cell population is? Your bone marrow. All right. So, but if you make too many, for instance, if you have too much signaling to make red blood cells, we call that polycythemia. So if you have an increase in red blood cells due to signaling and so forth, that's called polycythemia. But that process of making red blood cells is collectively known as erythropoiesis. Hematopoiesis is the process of making all of the blood cells. Erythropoiesis is the process of making red blood cells, and they're distinct. They have an unusual biconcave frisbee-like shape. That's for surface area. They don't have a nucleus. They really don't have any organelles. They're really just bags of cytosol and protein. And because they can't regenerate proteins and they really aren't all that reactive to changes in the environment, assuming no real stresses, they'll only live about 4 months. But they are filled with hemoglobin, and the hemoglobin solubilizes oxygen. Oxygen just doesn't dissolve very well, 2% or something like that. It's very, very low. And so you need hemoglobin to do this. And so to make red blood cells, you have to have, first of all, you have to have the ability for cells to divide, the ability for cells to handle iron. So B12 helps us bring in iron from the digestive tract. Remember, iron's really, really reactive, so we don't want that hanging, by itself. So we chaperone it. Folate's involved in cell division. That's why pregnant women are often recommended to take a little bit of folic acid, especially early in pregnancy, because of the rapidly dividing cells. You certainly need iron and then copper and zinc and some other things. You don't want to be low in those, but you also don't want to be high in those either. Those are important for enzymatic functions in proteins. Testosterone, that sort of thing. That's partly why guys have higher hematocrit than gals most of the time. All right. Now, one enzyme that we find inside the red blood cell is called carbonic anhydrase. Now, we've alluded to this a little bit, and I don't want to get too technical along these lines, but carbon dioxide will react with water. All right, and it will form carbonic acid, and that carbonic acid will give off a proton somewhere around pH of 7.4 and form bicarbonate. Well, what the carbonic anhydrase enzyme facilitates is this reaction of taking CO2 and water and forming carbonic acid. Or when we get to the lungs and we are bleeding off CO2, converting bicarbonate back into CO2. So if you breathe out right now, that just a few seconds ago, carbonic anhydrase helped convert this molecule back into CO2. All right, 80% of your CO2 is carried by bicarbonate. And about 20% or so, there's a little bit of fudge factor here. So there's some other places that about 20% is carried on the hemoglobin. CO2 is a mild competitor for oxygen. It doesn't have as much affinity as oxygen, but it will compete off a little bit of oxygen. We call that carbamino hemoglobin. The protein hemoglobin is the protein that's found in great abundance inside red blood cells. It is a 4-protein complex, 2 alphas and 2 betas, and each of those 4 proteins handles a heme group, which is a carbon ring structure that cages an iron, and the iron reactivity is what solubilizes oxygen. So there's 4 oxygen per hemoglobin when it is fully bound. We call that oxyhemoglobin. If we're lacking oxygen, we call that deoxyhemoglobin. Now, red blood cells are created in response to low availability of oxygen in the tissues. So if you have some reason that you have increased breakdown, like for instance a parasitic infection, malaria, or anemia of some kind, loss of red blood cells, hemorrhage, or if you're at a high altitude, now the partial pressure of oxygen is lower, which means that the blood isn't getting as saturated when you have exchange in the alveolus. So you just make more red blood cells. Persistent aerobic exercise regimens, where increased metabolic need is present, will stimulate development of additional red blood cells with hemoglobin. And then chronic lung disease, where you have decreased levels of O2, increased levels of CO2 because of inefficiency of gas exchange. So patients on hemodialysis have low RBC counts. Why? Because that process of dialysis does lead to increased destruction of red blood cells, and in some cases a little bit of red blood cell loss in the process of dialyzing that blood. Hemolytic diseases, and this is things like I said, malaria. There are other ones. Persistent drug use can lead to elevated breakdown rate, and again, so anything that would cause liver failure, things that would cause increased breakdown or decreased production. Now it says here, know the pathophysiology of hemolytic disease in the newborn. We're going to get to that in a few slides. All right. So understand that process. That's super important, and we'll explain the reasons why. When a red blood cell ages out, it gets kind of raggedy. It doesn't have any way of regenerating itself because it doesn't have a nucleus, doesn't have any organelles. So it's sort of a one-way street for these cells. They just have to be recycled, and that usually occurs about 4 months, about 120 days after creation of that red blood cell. Now, the main technical issue when breaking down a red blood cell is the iron. We do not want the iron to be by itself. So in the red blood cell, it's caged in heme inside the hemoglobin, and so when we break that red blood cell down, we're going to take that heme and immediately convert it through a couple of steps to a molecule called bilirubin. So bilirubin is the primary metabolite of heme. Now, the protein itself will get broken down into amino acids and can be reused for other purposes. But we got to still deal with that heme. And now it's bilirubin. Now, some of that bilirubin can be taken to the liver and the iron stored in the liver. And that's why the liver is a dark purple red. The vasculature and the abundance of iron in the liver gives it that color. So some iron is stored. But a lot of the bilirubin is actually lost. We lose it through urine, that's possible, but the big chunk of bilirubin is lost through the bile. So that's why it's called, in part called bilirubin. It's secreted into the intestines and then released as feces in the end here. It's a multi-step process, but the majority of the bilirubin is actually the fecal route. And that makes the fecal route as important a drug elimination route as urine. We tend to give urine a little more credit in that regard, but that's actually not true. Feces are actually a large part of drug excretion. If that iron needs to be recycled from ferritin, we will again hand it off to a molecule that it will hold on to it, transferrin, send it into the bone marrow, and then create a new red blood cell with hemoglobin. But bilirubin is excreted in the bile, which goes to the fecal route, and in the urine, which gives it partly gives it its color. It's also what we see in bruises. So when we see the yellowish, sometimes greenish tint of the bruise, that's called ecchymoses. That's a fancy word for bruise. And if you have a buildup of bilirubin, that's what gives the sclera of the eyes or the skin, if you're a fair-skinned person, the yellowish tint, jaundice. Normally, we're breaking it down into other products beyond bilirubin, and that's why the brown color is feces, because it's converted a little bit further. Same thing with urine. It's not really bilirubin in the urine, it's a urobilin. Since blood is intimately involved in immune responses and mediating, defenses in the body, there's a lot of activity that goes into determining whether something is what we call self from our bodies or non-self from another body or another organism. One example of this is blood type. So we have ABO. So you either have A, you have B, you have AB, or you have O. Those letters designate the array of a glycoprotein known as an antigen. An antigen is usually a molecule that is able to elicit an immune response. In fact, autoimmune diseases are where we no longer can discriminate self and non-self and begin attacking our own tissues. So if you have A-type blood, that means your red blood cells have a glycoprotein on the surface called antigen A. For reasons we don't fully understand, you will also have antibodies to the B antigen shown here in the purple triangle. Even if you haven't been exposed to B blood, it's a little bit of a mystery. Why would you have B antibodies if you have not seen B? Normally, you have to have been exposed to something in order to have antibodies. All right, so you'll have plasma that will react with B antigen. B-type blood, the B antigen is on the surface of the red blood cells, and you have anti-A antibodies. So if you introduce this blood into the B person, they would begin attacking it with antibodies. Some people are AB. The A and B are dominant phenotypes. So if you have A antigens and B antigens, they'll register on the surface. And so you have A and B, and you don't have either of those anti-A or anti-B antibodies. All right, so this would be a universal recipient of a sort. All right, we often call these people universal recipients. There's a little more complexity to it, but at least we can go with that for right now. O-type blood has neither A nor B and happens to have both anti-A and anti-B antibodies. Now, we call O's, especially O negative, as universal donors. The issue, though, is that you have to do something about these antibodies, because you give it to somebody with A or B, or AB, you're going to have these antibodies, and that can cause problems. So there are procedures involved to mitigate that. But we call O negative, and there's a third antigen that's called the rhesus factor, so you can be positive or negative for that. We call O negative people universal donors. Over here on the right is how we tell whether you have antibodies or not. So you have A, anti-B, and then anti-D. So if you're positive, you would be positive for the D. So you get this hemagglutinin reaction with the D. But you don't have the reaction with either the A or the B. Let's look at AB positive. You can see that they have agglutination for all three. They are positive for A, positive for B, and positive for the rhesus factor. And so forth. O negative, 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 negative. All right, they are the universal donors. This chart here extends that, and you don't get caught up too much. All right. Remember that D antigen is the Rh factor. It's the rhesus factor. So if you are O negative, you have neither A nor B nor D. Okay. AB positives are universal recipients. O negatives are universal donors. Now we're kind of making this a little more complex. If we're talking about whole blood, then this is what we've been talking about. But this is plasma. And what is plasma? Plasma is the liquid from blood where the antibodies have been removed. So it flips. So you're a universal blood donor as O negative, but you are a universal recipient of plasma. AB positive, You are a universal recipient of blood, whole blood, but you are a universal donor of plasma. So there's a little bit of a funky thing going on. There's a lot more going on than A, B, and D that makes this possible. But it's an interesting flip. All right, it's an interesting flip from universal recipient to donor when you go to the plasma, donor to recipient when we're talking about plasma, blood versus plasma. Now, it's hard for me to do this in this asynchronous lecture, but one of the common tasks you're going to be tasked with is determining blood compatibility in the clinic. And so what you do is you follow these steps and then you look at a hypothetical chart for what that patient could theoretically receive. So you get the type of the blood. You can always donate and receive the same type. So AB positives can receive AB positives, O negatives can receive O negatives, et cetera, et cetera. Then what you do based on their blood type, you determine what the antigens are and the antibodies are. So if let's say they're A positive, all right, that means they have both the A and D antigens, but they are going to have, because it's only A, they're going to have B antibodies. And so they can either receive A positive, or they could receive A without the rhesus factor, A negative, or O positive, or O negative. They cannot donate to anyone with the B antigen because of the A antigen. So that's the secret, and you should work and you should practice this. Because of a slide like this, I would strongly encourage you to be able to work through what's the blood type? You'll be given that. Maybe you'll have an agglutinin reaction thing going on from the previous slide. Figure out what the antigens are and if there are antibodies. If they're O, they're going to have both anti-A and anti-B. If they're O negative, they're going to have anti-A, anti-B, and anti-D. All right, and then you can decide, okay, which type can they receive without having that reaction. So here's the promised slide on hemolytic disease of the newborn. And this is a big, big deal. In fact, there was a guy in Australia. He was called the man with the golden arm because he had a special antibody in his blood that would counteract the antibodies involved in this hemolytic disease of the newborn. And so, and this actually happened in my family. My dad was O positive at birth. My grandmother was O negative. So usually the firstborn in a family is not affected by this. But if you are Rh positive fetus and your mother is Rh negative, what happens is the act of pregnancy and childbirth gives rise to anti-D antibodies. All right. Anti-D antibodies that can cross the placenta and attack the fetus. All right. This only happens if the baby is Rh positive and the mom is Rh negative. All right. And only after the first pregnancy. Problems arise on the second pregnancy. So my dad was an only child because the second child, when my grandparents conceived, my grandmother had anti-Rh antibodies that could cross the placental barrier, attack the fetus, and led to a pretty nasty miscarriage. So what has happened is the gentleman in Australia had anti-RH. Okay, it was a negative of a negative, and so he gave blood for years and years, and he is credited for saving over 2 million lives. Because this medication, what they do in the United States, we have this drug called Rogam. All right. And Rogam is given to Rh negative mothers to prevent the development of these Rh antibodies. He had antibodies in his blood that would negate the anti-Rh antibodies. And so they would take his blood, they would isolate the antibodies and give it to Rh negative mothers. And again, he had the man with the golden arm, just passed away in the last month. Pretty amazing story, right? But the long and short of it is that the first pregnancy, if it's an Rh positive fetus, Rh negative mother, the mother will develop anti-Rh antibodies, and that can then have the potential to attack the fetus during the second pregnancy, and it will destroy their blood cells. That's why it's a hemolytic disease. It's erythroblastosis fetalis. The antibodies attack the fetal blood, and so the fetus can't circulate blood, and the fetus dies in utero. And just a little bit of dad humor here at the very, very end. Two blood cells met and fell in love, but alas, it was all in vain. All right. So thank you for your time today. I hope you enjoyed this lecture. It's kind of a fun one to teach. Don't get bogged down into the technical stuff. Take your time. Take your time. Have patience with the physiology of learning, and it will all work out. Good luck, and I will see you soon.